So again, this is Orlando GI Journal Club for March. Good morning, everyone. Our first study is a randomized trial that was published in JAMA Internal Medicine. This was a randomized trial looking at the effect of disposable elevator cap duodenoscopes on persistent microbial contamination during ERCP. So there has been a sharp increase in global reporting of duodenoscope-related infectious outbreaks, with majority of outbreaks unrelated to identifiable breaches in disinfection protocols. In a nationwide study from the Netherlands, 22% of duodenoscopes were persistently contaminated after high-level disinfection. And duodenoscopes with disposable elevator caps have been developed in order to try and mitigate this issue with microbial contamination, but potential for reduced contamination of these duodenoscopes remains unproven. So the aim of this randomized trial was to evaluate microbial contamination rates and technical performance of duodenoscopes with disposable elevator caps compared with standard designs. So this was a randomized trial conducted in 2 centers in Canada using Pentax duodenoscopes. Patients were randomized to one-to-one ratio to either ERCP using disposable elevator cap duodenoscopes or ERCP using standard duodenoscopes. And they enrolled any patients who were undergoing an ERCP for any indication. They had a 30-day follow-up period. There were 2 co-primary outcomes, which was the persistence of microbial contamination following high-level disinfection, which was defined as growth of at least 10 colony-forming units of any or any growth of gram-negative bacteria within 72 hours of plating, and the technical success of ERCP. So they were able to enroll 259 patients in the disposable group and 259 patients in the standard group. And as you can see, the majority of procedures performed were grade 2 ASG complexity for ERCP complexity. And in terms of cannulation achieved, it was able to be achieved in around 94% of cases. And procedure time was about 14 minutes for the disposable group and 17 minutes for the standard group. When they looked at the rate of duodenoscope contamination, they found that the rate of contamination was 3.8% in the disposable group, 11.2% in the standard group, which was statistically significant with p-value of 0.004. When they looked at the number of scopes with at least 10 colony-forming units or growth of gram-negative bacteria, they found that the majority of cases was taking place within the instrument channel, 2.4% for disposable, 9.8% for standard groups. When they were looking at the technical and safety outcomes of the ERCP, as you can see, there was no difference between the 2 groups, with technical success of 94.6% in the disposable group and 90.7% in the standard group. When they looked at the post-ERCP adverse event rates, again, there was no significant difference between the 2 groups, including rates of pancreatitis, bleeding, perforation, cholangitis, and cardiovascular events. When they looked at subgroup analysis for microbial contamination, they found that for each subgroup, the persistence of microcontamination was lower for the disposable group compared to the standard group. The limitation of this randomized trial is the short follow-up period of 30 days. They looked at the contamination of the scopes, but there is no data on the clinical significance of the duodenoscope contamination, including duodenoscope-associated patient infection. The follow-up period is simply not long enough for data to really be reported. Again, this is conducted at 2 centers from Canada, so there is some limited generalizability, including there is no associated study data on local microbial growth patterns outside of the 2 study centers here. The other limitation is the relatively low rate of ELCP, low number of ELCP procedures of high ASG procedure complexity of grade 3 or 4, which may have affected comparison of technical performance between the 2 scope types, especially in the more difficult cases. And finally, there were no data collected on patient colonization or local antimicrobial resistance patterns. The take-home point from this randomized trial is that disposable elevated cap duodenoscopes exhibited lower persistent microbial contamination rates following high-level disinfection compared to standard duodenoscopes, while maintaining non-inferior technical performance of VLCP and similar safety outcomes. Our next randomized trial, or next study, was published in Annals of Internal Medicine, looking at cold versus hot snare polypectomy for small colorectal polyps. All right, so this study is important in our clinical practice because polyps less than 10 millimeters in size comprise nearly 90% of polyps detected at screening colonoscopy. Hot snare polypectomy using electrocautery is commonly used to remove polyps. However, arteries in the submucosa may receive thermal injury during electrocautery, risking subsequent delayed bleeding, post-polypectomy syndrome, and perforation. The rate of delayed bleeding following hot snare polypectomy have been reported as ranging from 0.07 to 1.3% and up to 14% in patients on anticoagulation. Prior studies failed to demonstrate superiority of cold snare polypectomy over hot snare polypectomy due to insufficient statistical power. The aim of the study was to evaluate the rate of delayed bleeding in patients undergoing hot snare polypectomy and cold snare polypectomy for removal of small colon polyps, 4 to 10 millimeters in size. So this was a randomized trial. It was an open-label, single-blind superiority trial conducted in 6 centers in Taiwan. They looked at patients at least 40 years of age undergoing screening colonoscopy with at least 1 polyp-sized 4 to 10 millimeters in size and randomized a 1-to-1 ratio to either hot or cold snare polypectomy. Endoclips were not routinely used and used only for exposed vessel within the resection site or if bleeding developed after polypectomy. The follow-up period, again, was short in the study at 2 weeks. The primary outcome was the rate of delayed bleeding, which is bleeding that develops within 2 weeks after procedure. So they were able to enroll over 4,000 patients in this randomized trial, 2,137 in the cold snare group and 2,133 in the hot snare group. And as you can see, 2% of patients had history of colorectal cancer, around 9% of patients had history of colon cancer. Anticoagulation use was in about 2.4%. And colonoscopy was able to be completed in 99.3% of cases. When looking at the polyp characteristics, the mean size of the polyps was around 6 millimeters in both groups. About 53% in the proximal group, about 46% in the distal colon. And when looking at the pathology, 0.6% of the polyps were cancer compared to 0.3% in the hot snare group. When looking at the primary outcome of delayed post-polypectomy bleeding, they found that the rate of delayed post-polypectomy bleeding was significantly lower in the cold snare group at 0.4% compared to 1.5% in the hot snare group. And this difference was significantly different. When they looked at bleeding, compared the rates of bleeding, which stopped spontaneously, okay, the rate was lower in the cold snare group at 0.3 versus 1.1% in the hot snare group. And when they also looked at the rate of severe bleeding, the rate was significantly lower in the cold snare compared to the hot snare group at 0.05 compared to 0.4. They also looked at other secondary outcome measures, which included the time for polypectomy. Again, this was significantly lower for the cold snare group compared to the hot snare group. And when they looked at the mean and total procedure time, this was also significantly lower for the cold snare group at 8.5 minutes compared to 9.5 minutes in the hot snare group. The limitation of this randomized trial was that colonoscopy was not performed in all patients with bleeding, and therefore actual bleeding site was not identified in all patients, and colonoscopists were not blinded to the polypectomy technique. However, staff performing outcome assessments were blinded to the technique used. The take-home point from this randomized trial is that cold snare polypectomy compared to hot snare polypectomy for small colorectal polyps significantly reduces the risk for delayed post-polypectomy bleeding, including severe bleeding events. The next study is a study published in Annals of Internal Medicine looking at adenoma detection rate and colorectal cancer risk in fecal immunochemical testing screening programs. This study is important because colorectal cancer screening programs based on fecal immunochemical tests represent the standard of care for population-based interventions. FIT tests or fecal immunochemical tests act as a filter to select a subgroup of target population at high risk for advanced neoplasia. Therefore, ultimate effectiveness of colonoscopy is related to the detection and removal of precancerous lesions and early invasive cancer in colonoscopies of persons with positive FIT results. However, colonoscopies are not perfect tests. 15 to 30% miss rates do occur, and there's a high variability of adenoma detection rate among endoscopists. In FIT-positive patients undergoing colonoscopies, ADR is increased by 20% due to enrichment of adenomas in this group. So the aim of the study was to assess the relationship between individual endoscopists' adenoma detection rate and an advanced adenoma detection rate, and look at the risk of post-colonoscopy colorectal cancer risk in a FIT-based screening program. So these authors performed a retrospective population-based cohort study in Italy, and they looked at all patients with a positive FIT test who underwent colonoscopy between 2003 and 2017. And they used a screening program database to look at the adenoma detection rate for each of the physicians enrolled in the study, and they linked this data to the regional tumor registry to look at the incidence of post-colonoscopy colorectal cancer rates. So they conducted a follow-up up till December 2021 to look at the diagnosis of colorectal cancer until death or until migration of that patient. The primary outcome of this patient was to evaluate the incidence of post-colonoscopy colorectal cancer colorectal cancer, which was defined as any cancer occurring at least 6 months after the index colonoscopy. So the baseline characteristics were as follows. What these patients did was they divided the patients into 5 groups, depending on the endoscopist's adenoma detection rate, ranging all the way from 20% to 70%. And as you can see, they were able to identify nearly 50,000 patients who underwent colonoscopies during this period. And the groups were fairly evenly spread, with the lowest number of patients in the 40 to 45% ADR group, and the highest number of patients in the 55 to 70% ADR group. When they looked at the characteristics of the colorectal cancer detected at follow-up, they were able to identify 277 out of the 49,000 patients who underwent colonoscopies who had colorectal cancer within or at least 6 months after their screening colonoscopy. And if you look at the proportion of patients with colorectal cancer and look at the incidence in each of the ADR category, the highest incidence of post-colonoscopy post-colonoscopy colorectal cancer incidence was the highest in the ADR group of 20 to 39.9%. And as you can see, the greater the ADR for the endoscopist, lower the incidence of post-colonoscopy CRC, ranging from 31% all the way down to 14.1% for the 50 to 55% group. They then calculated the risk of post-colonoscopy colorectal cancer based on the adenoma detection rate, and then when they conducted an adjusted rate and looked at the risk by calculating hazard ratio using the incidence in the ADR group for 50 to 70% ADR group as reference, the risk of developing post-colonoscopy colorectal cancer increased with decreasing ADR, going from 1.01%, going from hazard ratio of 1.01 for the 50 to 55% group, and all the way to hazard ratio of 2.21 in the 20 to 39.9% ADR group. So this means that compared to an endoscopist who has a ADR of 55 to 70%, if you get your colonoscopy by a physician with ADR of 20 to 39.9%, you are more than 2 times more likely to develop post-colonoscopy colorectal cancer. When they looked at the adenoma detection rate and looked at for every 1% increase in the ADR, they found that there was a significant decrease in the hazard ratio for developing for developing post-colonoscopy colorectal cancer. They also graphically represented this table looking at the post-colonoscopy colorectal cancer cumulative incidence per ADR group. And again, it's showing the same thing. Higher your ADR, lower the cumulative incidence of colorectal cancer following colonoscopy per 1,000 persons. The limitation of this study is that ADR is partly determined by FIT positivity, cutoff, and the exact values do vary in different countries. Post-colonoscopy colorectal cancer seen among patients examined by endoscopists in highest ADR group could be partly increased by surveillance bias, i.e. it is more likely that adenomas are found in patients scoped by high detectors, leading to these patients to be more frequently recommended to shorter surveillance intervals, thus resulting in overdiagnosis of subclinical post-colonoscopy colorectal cancer. Lastly, many colonoscopies were excluded, including those with incomplete exams, poor bowel preps, which may limit the generalizability of the results in a real-world context where you do end up having incomplete examinations and plenty of patients with poor bowel prep. So the main take-home point from this study is that in a fit-based screening program, adenoma detection rate is inversely associated with post-colonoscopy colorectal cancer risk, mandating appropriate colonoscopy quality monitoring. Increasing the endoscopist's adenoma detection rate may significantly reduce post-colonoscopy colorectal cancer risk. Our last study is looking at the risk of liver fibrosis associated with long-term methotrexate therapy, and that it may be overestimated. This is from Journal of Hepatology. This study is important because methotrexate has been widely used as a disease-modifying drug for the treatment of rheumatoid arthritis and psoriasis for several decades. The main clinical concern regarding methotrexate arises due to potential risk of significant liver fibrosis with prolonged methotrexate exposure, estimated at 3.5 to 7%. However, the incidence is derived from retrospective studies which underreported the risk factors for liver disease, such as obesity, diabetes, and alcohol use. The aim of this study was to establish the association between methotrexate exposure and liver fibrosis in a large cohort of patients with rheumatoid arthritis or psoriasis, using two validated non-invasive surrogate measures for fibrosis, the transient elastography and enhanced liver fibrosis blood biomarker panel. This was a longitudinal cohort study conducted in the UK with data pulled from 6 centres. They were able to enroll 999 patients, and these patients all had rheumatoid arthritis and also psoriasis, and they divided the patients into 2 groups. Those who received methotrexate for at least 6 months prior to recruitment in the study, or no methotrexate, as in they never received methotrexate. All patients underwent estimation of liver stiffness using transient elastography, and the cutoff for advanced fibrosis was 7.9 kPa, and anything above 11.5 was determined to be consistent with cirrhosis. And they also looked at the enhanced liver fibrosis score, looking at blood work, and anything less than 9.8 was determined to be there was cutoff of score of 9.8, above which the patient was determined to have advanced fibrosis. So they looked at the baseline characteristics. There was significantly a high number of patients in the methotrexate group at 876 compared to 123 in the no methotrexate group. There was some imbalance in the baseline characteristics between the 2 groups. Patients in the methotrexate group were significantly older. There were also significantly more women in the methotrexate group compared to no methotrexate group. About 70% of patients had rheumatoid arthritis in the methotrexate group. 45% of patients had rheumatoid arthritis in the no methotrexate group. Right. When they looked at the liver stiffness between the methotrexate and no methotrexate group as determined by transient elastography, they actually found that there was no significant difference in the proportion of patients who were determined to have advanced fibrosis. So liver stiffness score of at least 7.9 with a rate of 14.5% in the methotrexate group compared to 20.7% in the no methotrexate group, which was not statistically significant difference with p-value of 0.08. But when they looked at the proportion of patients who had score of at least 11.5, so consistent with cirrhosis, actually the rate was higher in the no methotrexate group at 11.6% versus 5.5% in the methotrexate group, which was also statistically significant. When they performed a regression analysis to look at factors associated with elevated liver stiffness, so a score of at least 7.9 kPa, they found that the cumulative dose of methotrexate was not a significant factor, with adjusted odds ratio of 0.99 and p-value of 0.68. They also looked at the liver fibrosis score as determined by looking at blood biomarkers. Again, when they looked at the rate of patients who were determined to have who had high EFL scores, so consistent with advanced fibrosis, again there was no significant difference between the two groups, with rate of advanced fibrosis of 29% in the methotrexate group compared to 35% in the no methotrexate group. Again, if they look at patients determined to have cirrhosis based on the ELF scores, again, there was no difference between the two groups with rate of cirrhosis in these patients at 2.9% for both groups. When they also looked at factors associated with elevated ELS score of at least 9.8, they did find that the risk was marginally higher with increase in methotrexate cumulative dose with adjusted odds ratio of 1.04 and p-value of 0.02. The limitation of this study is that the cutoff points used for liver stiffness and ELF scores are not validated specifically in patients with psoriasis or rheumatoid arthritis and are extrapolated from available literature. So the take-home point from this study is that in this study, there was no association between methotrexate cumulative dose or duration and liver stiffness in patients with rheumatoid arthritis or cirrhosis. This indicates that the risk of liver fibrosis due to methotrexate might have been overestimated in this population who is at higher risk of metabolic syndrome and non-alcoholic fatty liver disease. The study supports the current evidence on the need to improve the patient's metabolic risk factors that are associated with liver fibrosis. So to recap, in the first randomized trial, disposable elevated cap duodenoscopes exhibited lower persistent microbial contamination rates following high-level disinfection compared to standard duodenoscopes, while maintaining non-inferior technical performance of ERCP and similar safety outcomes. Cold snare polypectomy compared to hot snare polypectomy for small colorectal polyps significantly reduces the risk of delayed post-polypectomy bleeding, including severe bleeding events. In our third study, in a fit-based screening program, adenoma detection rate is inversely associated with post-colonoscopy colorectal cancer risk, mandating appropriate colonoscopy quality monitoring. And increasing the endoscopist's adenoma detection rate may significantly reduce post-colonoscopy colorectal cancer risk. And in the final study, there was no association between methotrexate cumulative dose or duration and liver stiffness in patients with rheumatoid arthritis or cirrhosis. And this indicates that the risk of liver fibrosis due to methotrexate might have been overestimated in this population who is at higher risk of metabolic syndrome and FLD. And the study supports the current evidence on the need to improve patients' metabolic risk factors that are associated with liver fibrosis. Again, thank you so much for joining us this month. Today, next GI Journal Club is the first Wednesday of April, which is April 5th. Thank you so much. Please have a wonderful day, week and month. See you next month. Bye.